Good evening. My name is Lisa Lindley from the College of Nursing. I think we've all heard that healthcare reform has the potential to change healthcare in the United States. Tonight, let me show you how it's going to impact a group of kids by introducing the first enacted provision of healthcare reform entitled Concurrent Care for Children. This story starts with a IOM, Institute of Medicine report, seminal report that came out of the IOM in 2003 about the status of end-of-life care for kids. One of the key findings was that children at end of life really lacked access to care, even though they really had a need for it. We define hospice care as end-of-life care provided by a multidisciplinary team of providers, clinicians, nurses, physicians, social workers, pastoral care, provide bereavement care, respite care, pain and symptom management. Yet, there are some critical barriers to this care for children and their families. These barriers include the hospice eligibility rules themselves as defined by Medicare, Medicaid, and most private insurers. For example, the first one is that children have to have a life expectancy of 6 months to live. In addition, children have to discontinue all services, including blood therapies. These rules really place families in some awkward situations where they have to make some terrible choices between caring for their child and hoping for a cure versus discontinuing care and going to hospice. It also causes clinicians with the need to look at different diagnoses and clinicians to think about the prognosis. But then came healthcare reform. And in 2 paragraphs, we have changed how we take a look at eligibility rules for children. And I'm going to share those with you tonight. Those rules did not just come out of the sky. A lot of times we think about these policy changes. They're there one day, the next day they're initiated by Congress. This was a multi-year process where several states, with the advice and guidance of the Centers for Medicare and Medicaid Services, did demonstration projects where they showed that there was feasibility and cost neutrality of eliminating those 2 eligibility criteria. As a result, on March 23rd, 2010, when healthcare reform was signed, concurrent care went into effect for these kids. It was one of the first enacted provisions of the law. And that act will allow children who are on Medicare and Medicaid and S-CHIP hospice benefit may receive concurrent care for their terminal illness along with their hospice care. Our research in this area has indicated that concurrent care for children will have a positive impact on access for care. We believe that it'll increase utilization. Currently, less than 10% of terminally ill kids utilize care. Those that do stay in there for just a few days. We believe that this change in the policy will eliminate that choice that parents have between that terrible choice between hospice and care and increase utilization. In addition, care should be more affordable for families now. This little girl on 43 different meds. Her family's waiting to get on Medicaid to help relieve some of the cost burden of those medications, and that will be an assistance with this policy. There are some concerns, however, with access, and those are threats to access that are going on right now in many of the state legislatures, and those are conversations about cuts to Medicaid. One of the biggest conversations going on is about cuts to hospice care in Medicaid. States like Arizona, South Carolina, and Florida have all had conversations about cuts to hospice care in their Medicaid programs. We believe that may have an effect on access to care. We also think that concurrent care for children will positively affect quality of care. They will now have access to evidence-based hospice care. Many procedures are very painful for kids at end of life. They'll now have access to really the cornerstone of hospice, pain management. In addition, concurrent care will now provide family-centered care. In the old world, parents had to shut off those relationships with their treating physicians. In this new world, they can continue those relationships, those bonds of trust that they've had with those providers. In addition, we think there may be some concerns, however, with quality of care, and that's with coordination of care. These kids are medically fragile. They see a variety of practitioners like this oncologist, but they also see neurologists, rheumatologists, and a variety of others, and now we're going to be layering in a group of hospice providers. In addition, most hospice providers do not have the ability to share medical records electronically, and we believe that's going to have some concerns or problems with quality of care as we coordinate that care. In addition, there are some concerns about concurrent care with regards to timeliness of care. We eliminated one barrier with this law. We did not eliminate the other one. Children still have to wait 6 months to have that 6-month prognosis to live before they can enroll in hospice care. And current research says the earlier we can get them into hospice care, the better outcomes we have for kids and families. And finally, this concurrent care does not apply to children on private insurance. So folks that are on Blue Cross Blue Shield, for example, are not affected by this law. And we're a little concerned that there may be some disparities that emerge based on insurance type. Our ongoing research is taking a look at what's going on with hospice implementation at the state level. And we've really found some variety of this implementation. Early adopters like the state of Alabama adopted within the first 6 months. Late adopters like Oregon took over a year to adopt. And we've got some sort of what I'm calling non-adopters like the state of North Carolina. Overall, though, we believe that concurrent care is going to be a bellwether for the other provisions in healthcare reform. This is one of the first enacted. We've gotten to see how it affects delivery of care. We're getting to see how it impacts implementation. We believe that this is important for policymakers as they look at other provisions that are coming online in 2013 and 2014.